Okay, so without further ado, I think we'll start off with our first speaker. It gives me great pleasure to introduce Professor William Harrop-Griffiths, who I'll give you a little bit of an introduction, although he's a man that doesn't need much of an introduction. He qualified from Oxford and St Thomas's Hospital, my alma mater as well, and after training in London and Seattle, he was appointed as a consultant anaesthetist at St Mary's Hospital since 1991. He has a very active role in the Royal College of Anaesthetists. His specialty of interest, not surprisingly, is regional anaesthesia, and he's chair of the Clinical Quality and Research Board and also the ACCA lead. His other interests, worryingly for me, because I wrote a paper with him recently, are English grammar, bicycles and motorcycles. So it gives me great pleasure to introduce Professor William Harrop-Griffiths.
Thank you very much indeed for that wonderful introduction. Now, when we thought of the title for these talks about 4 weeks ago, it seemed like a very good idea to choose an opening title of Why Choose Regional Anaesthesia in the COVID-19 Recovery Phase, only to find that we're probably not sort of in the COVID-19 recovery phase. I'm going to talk more, not so much about why choose regional anaesthesia in the COVID recovery phase, but why choose regional anaesthesia right now. Now, before I launch into that, I want to admit my competing interests. They are that I've received honoraria from both B. Braun and Synthetica for educational activities, and that I'm a regional anaesthetist whose passion borders sometimes on absolute obsession. So you should think of that carefully before believing every single word I say. But I'm going to start out with a simple clinical story and a real story of two real anaesthetists. I work every other week in a specialist private orthopaedic centre in central London, and this particular centre prides itself hugely on doing almost all its cases as day cases. Even quite major orthopaedic surgery, it does as day cases. And every other Monday morning, I'm in one of the two operating theatres. I'm doing a shoulder list, and my friend and colleague, another fellow grumpy old git, you know who you are, Mark Kenny, is in the other operating theatre doing a foot and ankle list. I do all my cases under regional. He did all his cases under general. And we had the standard banter, which is regional versus general anaesthesia. He said that fundamentally regional anaesthesia was a form of perversion, whereas he pragmatically gave general anaesthetics, knowing that these patients could get out, walk out of hospital, hobble out of hospital later on that day. And then COVID-19 happened, and suddenly things have changed. And I can say with pride that this person now gives a substantial majority of his foot and ankle procedures under short-acting spinal anaesthesia very, very successfully. And that's what's really happened, I think, in a lot of places, that change of a number of different sorts has been driven by COVID-19. Now, one of the reasons behind significant change is this wee beastie here, SARS-CoV-2. And we think, and remember there's a lot we don't know about this virus, but we think it's spread in one or two or three different ways. One is by contact, direct physical contact with an infected person's phlegm or spit, or touching that once it's landed on a surface and bringing it to yourself. Another form of spread is by droplet. These are droplets of infected fluid from the upper respiratory tract of 10 microns or more, called droplets, and they have what's called a ballistic trajectory. They travel, but they're pulled down by gravity because they're quite heavy, and they tend to go no more than 2 meters. But the third and the most relevant form of potential spread to this talk this evening is airborne spread. If you put a very, very high velocity gas flow across a thin layer of liquid, you can create an aerosol. Now, aerosol, less than 10 microns in diameter, each particle can sit in the air for a considerable time as an aerosol and can infect other people. It can float for a very long time until eventually the tiny droplets desiccate and drop to the ground. And therefore there is an accent on aerosol generating procedures, or AGPs. Now, if you go to NHS England improvement guidance, and you go to Public Health Education and Public Health England guidance, you will find the phrase potentially infectious AGPs for COVID-19. Because that is not completely synonymous with AGPs. There are some aerosol generating procedures that create an aerosol that are highly unlikely to cause the transmission of COVID-19. And an example is diathermy. So diathermy does create an aerosol. It creates a blood aerosol, but COVID-19 virus is not fundamentally a blood-borne virus. It spreads by the respiratory tract. Yes, it's been found in blood. Yes, it's been found in feces, but there is no great concern about these aerosols that are not created from the upper respiratory tract. If you want to know what is considered an aerosol generating procedure in this country, in the United Kingdom, you go to that web address and you will find that document published by Public Health England. And it's worth looking at this particular phrase that's on the top page, the front page of that document. It says uncontrolled if printed. And it means if you take that document off the web onto your computer or you print it out on paper, it no longer definitely represents the latest version. Because Public Health England produce new versions not infrequently, and they don't always shout about what's in the new version. So you should always go and look at it on the web. This is checked today, the current list of aerosol generating procedures that can transmit COVID-19 disease. I'm not going to go through all of them, but I am going to call to your attention the third one, manual ventilation, and the fourth one, tracheal intubation and extubation. The other one that's worth looking at slightly lower down in the list is high-speed cutting in surgery or post-mortem procedures, but only if it involves the respiratory tract or paranasal sinuses. This document refers to a second document produced by NHS Services Scotland, and that's essentially a semi-structured literature review of the evidence supporting the production of aerosols in certain procedures and whether they can transmit COVID-19. This is what they say. They found no strong evidence for any aerosol generating procedure transmitting COVID. They found no moderately strong evidence. At best, they found weak evidence. This list provides weak evidence, and you can see there manual ventilation and performing tracheal intubation. Then there's an even longer list of procedures for which there is no evidence that they can produce aerosol that can communicate COVID-19. The first 5 on the left are highlighted in blue because they are actually aerosol generating procedures within Public Health England's document, but there's no evidence for them at all. That does not stop them being treated as AGPs, but it is being honest about the fact there is no evidence at all for them. So if you look carefully at that, you'll find there are some things that are not AGPs according to Public Health England. Tell your surgeons. If you are surgeons, tell yourself. Powered saws and drills outside of the respiratory tract, not an AGP. Diathermy, no. Laparoscopy, no. Laparotomy, no. Pulse lavage, no. These are not currently in the UK AGPs. Public Health England stays remarkably quiet on supraglottic airways. It doesn't commit itself one way or the other. And so as a result, we have to take certain things as aerosol generating procedures. Now, I will reveal to you that there are some ongoing studies that may suggest that some of the things that we think are AGPs are not in reality AGPs. I'm not going to call them out which ones they are, but they are of relevance to anaesthetists. They are being examined scientifically. There will be changes to that list. I'm confident in the next few weeks, so keep an eye on it on the web. But for the time being, airway manipulation under general anaesthesia is an AGP. However, breathing spontaneously with a capno mask is not an AGP, and regional anaesthesia with no sedation, mild up to moderate sedation without coughing is not an AGP. And one of the problems is that AGPs come with a deal of baggage. Airborne precaution, I don't like wearing airborne precaution PPE. I will wear it. It takes a while to put on properly. It takes a while to take off properly, and it's unpleasant to wear for any particular time. But there are other things that AGP causes. For some reason, we're not allowed to give anaesthetics in the anaesthetic room anymore. We have to give in the operating theatre. And although there may be logic behind that for a patient with rampant COVID, there is less and less logic in that change for a patient who has had a series of negative antigen tests or perhaps been self-isolating at home. It just seems to be a standard response by some theatre managers. When anything goes wrong, we're not allowed to use the anaesthetic room. But the most important issue from our point of view is the fact that you have to wait for aerosol clearance after an AGP. PHE says 20 minutes. In reality, it's 5 air clearance times if you measure the air circulation rate in your operating theatre. So if it's 20 air circulation, air exchanges an hour, each one's 3 minutes, 5 of those is 15 minutes. But you need to know what your air exchange rate is. And you've got to weight that at the beginning of general anaesthetic and at the end. But this is the other bit of baggage with AGPs. And I don't know whether it's happening in your hospital. It's certainly happening in my hospital. There is, how can I put it, it's nobody's fault, but there's a very relaxed attitude. And if everybody doesn't get a 45-minute break between cases, people get slightly upset. Everybody's relaxing. It's a kind of a mindset which has come about because things take so long. We need to bring back a greater sense of urgency. The reason to use regional anaesthesia, 3 minutes out, not long to go. Planned surgery ground to a halt in the UK during the COVID surge. We've got to get going again. We could perform, under the current rules, a lot more surgery safely if we used more regional anaesthesia, because we know that because the regional anaesthesia and an awake or lightly sedated patient is not involved in aerosol generation, that you don't need that downtime to clear aerosols and airborne infection. Back on Friday, the head of the NHS, Simon Stevens, wrote this letter to all the people who run the trusts and hospitals within the UK. Look at this. Having carefully tested the feasible degree of ambition with a number of trusts, we're now expected to re-establish services to deliver in the NHS. In September, at least 80% of last year's activity for overnight electives and for outpatient day cases, rising to 90% in October. That's compared with last year. You've got to be at almost 100% in 2 months' time. Notice the wording. They've tested the feasible degree of ambition. They haven't tested the degree of ambition. It's the feasible degree of ambition. If we're going to get anywhere near there, we'd start to need to do things differently and more effectively. There are many benefits to regional anaesthesia. Genuinely, I'm not going to list them. But even outside of a viral pandemic, there are superb reasons for making regional anaesthesia your first choice. I've been doing so for the last 30 years. But now there is an extra pressing need to increase turnover, to get those patients who've been waiting, while waiting on the waiting list, getting sicker, their conditions getting worse, getting their planned procedures done. And regional anaesthesia, I put in for once for the skeptics, can be a lot quicker than general anaesthesia because of the current regulations about the management during a COVID pandemic. There will be legacies to COVID-19. It may be that video conferencing will be seen as having come of age, and we'll be doing this sort of thing a lot more frequently. We'll look back and say that's when working from home became the norm, when cycling got really popular, and when waistlines expanded and livers got severely punished. Hopefully, we'll also look back on COVID-19 and say it was the time when general anaesthetic Luddites gave regional anaesthesia a go. Now, it takes a lot of time to learn how to do a PEX 15 or a tequila 26 block or whatever the latest trunk block is that Amit Palmer was talking about, but anybody can do a spinal. Many planned and emergency procedures take place below the waist, and spinal anaesthesia and day case surgery mix. I could go on, I'm not going to, 1 minute to the end. With Amit and Alan, we wrote an editorial, not yet in paper, but it's there online, the British Journal of Anaesthesia, talking about all the issues related to regional anaesthesia and COVID. I would encourage you to read it. And it says, in a crisis, be aware of the danger, but recognise the opportunity, from John F. Kennedy. And the organisations did seize the opportunity. The OAA love epidurals, and they said, put in the epidurals early. The DAS, they different airway society, love video laryngoscopes. So they said, use video laryngoscopes all the time. Regional anaesthesia, who love doing blocks, say use regional anaesthesia. And the Society for Intravenous Anaesthesia, who were told that they couldn't give any intravenous anaesthesia because there wasn't any propofol or Remy, were upset about it. But watch out, because the regional anaesthesias will seize the opportunity. But I want you to seize that opportunity. If you're not a regional anaesthesia obsessive, it's a chance to show yourself that it can be efficient and effective, that you can use spinal anaesthesia reliably, even in day case surgery. And hopefully this change will outlast the COVID pandemic. Time for me to shut up, answer your questions, and allow other people to speak. Amit, over to you.
Well, thank you very much, William. That was a wonderful way to start our webinar. And as you might imagine, I've got a whole host of questions coming in. The first question is spinal anaesthesia better than a general anaesthetic in patients with COVID-19?
Do you know, it would be really for me to say, yes, of course it is, but you cannot be as general as that. This is an individual patient discussion. This is an individual patient decision. And I'm going to stress it's a patient decision. I personally think that all things being equal, it is of benefit to the patient to have a spinal where it is a feasible alternative. It is certainly possibly a benefit to the overall turnover of patients in the hospital. And you could even argue it's a benefit to those healthcare workers looking after that patient because there are no aerosols generated during the procedure. If it's not a head and neck procedure, it's a spinal, it's not going to be. But it's up to the patient. You evaluate the patient, evaluate what's best for them, tell them what you think genuinely is the best for them, allow them to take the decision. One of the questions that came up is, can you tell that patient that they may benefit healthcare workers if they go for a regional rather than general? I personally believe you can, because patients are lovely people, and they usually say, God, yes, you're doing a wonderful job for me. I want to help you every bit I can. I'll go for the spinal. Long answer, short question, but there you go.
Another interesting question. Do you think your colleague will go back to giving general anaesthetics only once this is all over, once the COVID-19 crisis is all over?
So I've had a word with the AGP, and he's going to hide all the propofol, so it's going to be very hard for him to go back to general anaesthesia. Do you know, this is going to be the really, I was talked about lasting legacies. I genuinely think, I'm not sure whether he will, but I think a lot of people who thought, you can't use spinal for a day case, it doesn't work. The fact that they have done it and shown to themselves that it works, that it's reliable and effective, hopefully will start to turn it around in some people's minds, and that many, perhaps not all of those who've made that change, will continue with that change. I personally believe it's for the benefit of the patients, but that's for individual anaesthetists to decide, not for me.
One more question, I think, before we go on is, are you biased towards regional anaesthesia when you're consenting the patient? And a follow-on for that is, how ethical is it to consent a patient for a procedure when we deem it's a healthcare worker that may be more to benefit?
The answer to that is I carry with me a bias, but the GMC is quite clear, although you must give a balanced view, you must give the patient the alternative treatments, the risks and benefits of the treatments, you as a clinician are allowed to express an opinion. Your opinion may be that general anaesthesia is the only thing to give, or it may be that regional anaesthesia is fantastic, but you are allowed to say that, in my opinion and experience, I think that this is the better way, or this is the way that I might actually do it. So you are allowed to say that, you are allowed to express an opinion. What was the second part of that question, Amit? Remind me.
Is it ethical to consent a patient for a procedure where it may be the healthcare worker that's the more likely to benefit?
There is no definite pronouncement from the General Medical Council, their equivalents across the world. That is for you to decide. I personally think that you shouldn't use it as a primary way of persuading a patient to have one or another. But if that patient is balanced on the cusp, I think a reasonable patient would like to know all the full situation, and as long as it's couched correctly and it's balanced, why not? Why not?
Perfect. I think we'll probably end it there. There are a lot more questions that have come through for Professor Harrop-Griffiths. What we'll hope to do at the end of this webinar is to answer some of those questions, and we'll put out a whole answer pack with answers to many of these questions. So some homework for you, Will, if that's okay. Thank you very much for a wonderful presentation.